Hello.
Hello. Yeah, hi, sir. Hello.
Yeah, hello, Naresh.
Yeah, yes, sir. Can you hear me?
Yeah, I can hear you.
Okay.
And how to change the background? Hello.
Sir, 1 second, sir. 1 second. I will stop this live stream. Okay. Yes, sir. Tell me, sir.
How to change the background? See, now I kept a blurred image.
Sir, already you have changed, now.
Yeah, I kept a blurred.
Yes, sir. Tell me, sir. How to change background? Sir, 1 second. I kept a blurred image. Sir, already you have changed, now. I kept a blurred.
Oh, what I changed? Blur my background and just choose video filter, choose avatar. No. Hello, can you hear me?
Yes, sir.
See, now I kept a blurred background. Okay, video.
Oh, okay.
How to change that? How to keep some buildings or other things?
Sir, 1 second. Huh?
Like office setup.
Hello. Hello, Govind sir. Hello.
Yes, tell me.
Yeah, I got a call. One second, hold on, sir. Sir, can
Okay.
you share your this thing video?
Yeah, yeah.
Okay. Beside video, na,
Ah,
if you choose one second, na, adjust background and effects.
uh, yeah, just background effects. Okay.
Adjust background and effects, and here you
Ah,
can see a plus button right side.
yeah, yeah. Virtual background.
Yeah. Just click that and add image
Okay.
from your laptop.
Oh, for that I need to have some image in laptop.
Yes, sir.
Okay. Okay. I will download something and then I'll keep.
Okay.
Okay. Sir, good evening, sir.
Hi, Govind. Good
Hi, sir.
evening. கேக்குதா?
கேக்குது சார்.
நான் டேப்ல ஃபர்ஸ்ட் டைம் பண்றேன்.
ஓகே.
மேபி அந்த லைட். ஓகே.
சார் ஸ்லைட்ஸ் ஷேர் பண்ணி பாக்குறீங்களா சார்?
இது எப்படி பண்ணணும் தெரியலையே.
அது கீழ இந்த ஷேர்னு சொல்லிட்டு ஒரு கிரீன் கலர் பட்டன் இருக்கு சார்.
ஸ்கிரீன்.
ஆமா, அது ஃபுல் ஸ்கிரீன் ஷேர் பண்ணிடுங்க சார் அப்படியே.
ஸ்டார்ட் ப்ராட்காஸ்ட். வருதா?
ஷேர் டிவைஸ். வருது சார்.
வருதுங்களா?
வருது, ஸ்கிரீன் வருது சார்.
என் ஸ்கிரீன் அப்படியே தெரியுதுங்களா?
ஆமா சார்.
நோ ப்ராப்ளம்.
நீங்க அந்த பிரசன்டேஷன் ஓபன் பண்ணி வச்சுக்கோங்க சார்.
பிரசன்டேஷன் இதுதான் இல்ல, கொரோனரி இன்டர்வென்ஷன்.
அது இல்ல சார், அந்த கால்சியம் சொல்லி வரும். அதுதான் சார். மேட்டின் வருதுல்ல.
தெரியுதுங்களா?
தெரியுது சார். கால்சிஃபைட் லீஷன்.
ஓகே.
ஃபுல் ஸ்கிரீன் போட்டுக்கோங்க சார்.
இது பிடிஎஃப் மாதிரி தான் ஓபன் ஆயிருக்கு ஆக்சுவலா.
ஓகே.
பிபிடி மாதிரி வரல.
பட்
இது நீங்க அனுப்பியிருக்கிறது பிடிஎஃப் தான்.
ஆமா சார். நான் அனுப்பிச்சது பிபிடி சார்.
இல்லையே, பிடிஎஃப் தான். slides. இதுல பிடிஎஃப் மாதிரி தான் ஓபன் ஆயிட்டு இருக்கு.
ஓகே.
நோ ப்ராப்ளம், இப்படி கூட பண்ணலாம்ல.
பண்ணலாம் சார், பட் ஃபுல் ஸ்கிரீன் தெரியல. நரேஷ்
இப்போ
slides. Hi sir.
நரேஷ், can you help?
Okay.
Hello, Naresh.
Hi sir, tell me sir.
Can you help sir in sharing the screen?
Sir, already shared, no?
No, whether that is okay, it is full screen or?
Yeah, it is already full screen come.
Full screen only.
Yeah, full screen.
Okay. So you will play timer, right, before the program?
Yes sir. Already
Okay.
3 minutes, no?
Yeah. See, after the timer, I will just give the welcome. Then
Okay.
sir will present the topic. Then finally, I will conclude and then close the program by 8:30.
Sir, once you hear the prompt that recording started, then you start live.
Yeah.
Okay.
But timer you will not play? 1, 2, 3 like that?
Should I give you a countdown?
Yeah, better now. Suddenly, if you tell start means, then we should be prepared.
Sir,
right?
what I'll do is once you hear the prompt, like recording started, you will hear in Zoom.
Okay.
And then you go live. Okay. I'll count 3. 1, 2, 3.
Yeah. Better.
Okay.
Yeah.
Is my audio good?
Yes, sir. Very good, sir.
I can't see me. Yeah.
go in. So is there a separate link for the attendees or everybody joining through this link only?
No, separate link.
Okay.
Sir, can we start the program, sir? I think it's 8 o'clock.
No, are you asking me, Govind?
Yes, sir.
Yeah, I'm ready.
Okay. So, Naresh, so we can start.
Madam.
Hello, Naresh.
Going, sir.
Yes.
3, 2, 1. We can go live.
Okay. So, good evening, all. I'm Govind from Abbott Vascular. So, on behalf of Abbott, I welcome you all to this webinar on topic stent choice matters in calcified lesions. So today we have Dr. Ashok Kumar. So he's the group director and head for the Department of Cardiology from Rela Hospital. I invite sir to share his presentation. Thank you.
No, yeah. Yeah, is my slides seen?
Yes, sir.
Okay. Now, ever since the COVID era started, we keep going into this virtual mode on and off. In fact, we were only surviving in the virtual mode earlier during the peak COVID time. Then, as soon as the COVID actually vanished, then we got into the reality. But this virtual platforms enabled us, and rather, made sometimes actually for the logistic convenience, to get into this virtual mode, and good in a way that our education and understanding and our practice actually gets better. Uh, with the, making these presentations and educational forums, easier for execution. So before I start, actually, I'm gonna run actually the slides actually shared by the abort team, and of course this is a sponsored talk on Zion stent in calcified lesions. Uh, we know. Thanks. At the outset, I would like to thank Awat, especially Govin, for the opportunity, and humbled with the introduction. We know for sure calcified lesions are actually difficult for achieving adequate procedural success, and poor procedural outcomes. Will invariably get reflected in poor clinical outcomes as well. It could be acute adverse clinical outcome, or in the long term chronic clinical outcomes as well. So chronic outcomes in the sense, probably requiring repeated revascularization, putting a burden of additional financial burden to the family, to the patient. And worse to that is the acute adverse clinical outcome, where the if stent poor procedural success could lead to stent thrombosis, and stent thrombosis, we know, is a catastrophe, and the mortality rates are much higher than native MI, or native vessel MI. Mm, so calcium prevalence of calcium is quite high, especially in the elderly age group. And as calcium burden is high in the vessel, technical or procedural success is likely to be much poorer. So requiring a better pre-lesion preparation, lesion vessel optimization by debulking technique. We know for sure. We are only evolving in that landscape. We started with special balloons like. Evolution started from a non-NC balloon to specialty balloons like cutting and scoring and high pressure opium balloons, and then novel techniques like orbital atherectomy, which debulks actually the calcium by sanding. It is actually in evolution or similar to the rotablation. Rotablation is available in the market for more than 2 decades now. So they are all the debulking techniques to debulk the calcium. Unlike fat or fatty plaque, which actually yields each dilates and yields to the pressure. To the NC balloon, the calcium is very difficult to be handled because it doesn't dilate much with the NC balloon, requiring this sophisticated or advanced techniques to debulk the lesion. And once lesion is adequately debulked, it is like any other angioplasty, putting a stent. But not it is not so easy as said. Debulking to the zero is not always a practical possibility, and there is a limitation. We achieve vessel diameter adequately, but the intimal surface could be corrugated and hard, and and could be tortuous as well, posing a significant challenges to the angioplasty procedure. Because the more tortuosity is the vessel or higher the calcium, there are high chances of stent getting dislodged, are difficult to deliver the equipment, be it balloon or stent, to the target lesion as a target of interest site. These are all the challenges. So even when we are pushing the hard or negotiating hard, the stent across these tortuous and calcific lesions, there is high chances the polymer might get actually disrupted, and stent may get dislodged. And all these complications actually increase the possibility of stent thrombosis or early vessel closure. That could reflect in clinical adverse complications like immediate, life threat, as well as sharp prolonged stay, and so on. So we for sure understand that calcium is a technically challenging for angioplasty. Vessel is prone for dissection during balloon angioplasty with an eccentric calcium precise, especially, and difficult to achieve adequate dilatation. Stent may go under expanded, asymmetric expansion, or there could be malapposition as well, even in a calcified lesions. So calcium inhibits optimization of PCI procedure, and unoptimized or poor PCI procedural will invariably gets reflected in a higher MACE, major adverse cardiac events. So presence of coronary anatomy calcification is growing up to 25% of patients. 1 in 4 are calcified lesions nowadays, and it could be even more actually in our Indian setting. And if left undetected and treated, calcium adversely impacts the PCI outcomes by limiting stent expansion. As I just said, it could be causing stent failure, stent thrombosis, and restenosis, increasing the clinical adverse outcome, as well as procedural cost and overall financial cost. When we are accounting the necessity for repeated procedures as well. So achieving optimal expansion is proven to reduce rates of MACE. So for achieving optimal expansion, lesion debulking and pre-lesion preparation is quite essential, which I discussed later a while. How do we get to know the calcium? Angiographically, of course, we get to see calcium because it's a radio opaque. And then, two planes, if you're confirming it with it in a two orthogonal planes, probably it's a severe calcium. But every calcium is not obviously well detected in conventional imaging or a radiographic imaging in cath lab. So for more precision or more sensitive observation of calcium in the coronaries, we need a better imaging techniques like IVUS or OCT available in the markets to pick the calcium, and not just to pick the calcium, also to establish the nature of calcium, intensity and depth of calcium, and the length of calcium. All these actually determine the modality of pre-dilatation lesion preparation methods, as well as also determine the choice of stent. Sorry, also determines the stent. Characteristics required for a procedural. For a better procedure, as well as to check if stent is well opposed and no edge dissections or something. For all this valuable information, we need imaging. imaging. And in imaging, see, these are OCT images where we see calcium as superficial calcium or deep calcium. Deep calcium may not be well observed in the IVUS. That's a limitation with IVUS. We get to see nodular calcium or eccentric calcium or concentric calcium. So the pattern of calcium, like nodularity or eccentricity as well as concentricity, also determines the pre-lesion preparation. Say if it's concentric calcium, IVUS could be IVL could be a better choice. Nodular or eccentric calcium, they don't do well with the majority of the modalities, but orbital atherectomy could be a better choice because it sands actually the vessel in a better shape. So based on the nature of calcium, probably the choice of debulking equipment, actually debulking strategy gets determined. So impact on PCI, impact of calcium on PCI, difficulty in delivering the stent, impaired drug delivery, polymer disruption, stent under expansion, which could lead to post-procedure stent thrombosis, restenosis, and long-term adverse event. Calcium in vessel can impact the procedural success and may cause clinical complications for the patient. Moment. Smooth stent delivery through complex lesions plays a big role in PCA success and optimal patient outcomes. Zymes is excellent. Deliverability is excellent, actually. I mean, modern day stents are better coated, especially the Zymes is, hydrophilic coated, actually makes it navigating the tortuous anatomy with ease, actually. And complex lesions. Compared to the market other stents. I mean, the modern stents are all good, actually. As CRI is observed to be much better to Synergy and Onyx in terms of deliverability to the distal lesions, negotiating the tortuous stent calcified lesions. Smooth stent delivery through complex lesions plays a big role in PCA success and optimal patient outcomes. Of course, Zymes is actually better in stent retention. The stent loss is a major issue in calcified lesions. We keep pulling and pushing in the interest of actually navigating the difficult anatomy. In the process, actually, the stent may get dislodged from the balloon, and the balloon actually may get missed out. Or if the wire assembly or entire assembly gets missed out, then stent is actually, stent floats in the coronary, or stent, I mean, completely gets dislodged in the coronary. That's a more catastrophe. So, and could lead to bad clinical MACE events, actually. So to avoid that, you need a better stent which retains the stent in spite of all our maneuvering. So Zymes is observed to be much better to the competitors like Synergy or Cera Onyx in this aspect. Stent retention and calcium, as I said, Zymes compared to Fireox, Synergy, Resolute, Onyx, and Orsero retains a better retention characteristics compared to the modern modern gen stents among the competitors. Stent polymer and calcium. Zymes has excellent polymer coating that remains intact even with in navigating the difficult complex anatomy, and that's been observed to be perform better with the competitors as well. Uh, Polymer integrity is critical for optimal long-term patient outcomes. So any disrupted polymer could actually invade stent thrombus and restenosis and so on and so forth. Stent polymer and calcium, I mean, delamination of this polymer occurs quite easily in this test, actually. With a, I mean, Zyme stent being a durable polymer performs well in calcified lesions, reducing the risk of potential adverse events. Various Synergy and Termos Ultimas, they're all not durable polymers, but I mean, polymer get lost within a month and dissolved within a month. So the frequency of late stent thrombosis is quite low in Zymes compared to other stents, and the percentage of uncovered stents is also observed to be very low, irrespective of degree of calcium, because the lesser this uncovered stents, the lesser is the inflammation in the vessel, leading to lesser adverse clinical outcomes, and the severity of calcified lesions also predisposes to the adverse outcomes among CKD patients. We know CKD patients are vessels of CKD patients are quite, I mean, easily calcified, or what's their calcific nature is quite high, posing even more difficulty in achieving procedural success. So Zymes matters more in CKD patients because CKD patients obviously are have got I mean, likely to possess a calcified coronaries. And for treatment of calcified lesions, appropriate and aggressive lesion preparation prior to stenting may be associated with better outcomes, as I discussed in my initial part of presentation. So you need to have a better clarity on the nature of calcium that will help you in deciding and strategizing the modality for debulking, and the better the pre-lesion preparation is done, the better is the chances of stent expansion, apposition, and the stent is well expanded up and well posed without any asymmetry. So the chances of long-term better outcomes are quite high, poor outcomes much lesser. So Zion's 10 peak to valley design delivers uniform scaffolding for even drug distribution, better vessel support, and minimal plaque prolapse. So its unique strut architecture actually helps in actually uniform drug distribution, as well as actually good achieving a good radial strength, and that helps in getting a good vessel support and minimizing the plaque prolapse. So Zion's unique polymer as well as uniform design contribute to better stent to wall opposition, and impacts the minimal late stent lumen loss. And Zion's is observed to do better competitors. And OCT optimizes treatment post PCA by helping recognize under expansion due to calcium. OCT is a better modality of imaging to IVS actually for its better resolution, as well as ability to identify deep calcium in this regard for calcium. Calcium assessment and depth of calcium assessment. And not just that, even the post-procedural success outcomes are adequacy of stent, implantation can be judged and determined by this OCT imaging modality in a better precise way. So Zion Stent has been consistently delivering unparalleled patient outcomes for different patient groups and various lesion types, and that's the legacy is known for decades now. So and no doubt it's a market leader, and it's for the industry about team to take their market volume and market share, and speak on market share and market performance. So with that, I'll probably conclude it here. Thank you all. We'll be happy to take any questions.
Thank you, sir. Thank you for the great presentation, sir, on calcium. So I think we have more than 25 audience. So if any questions, you can put it in the chat box so that sir will answer. Sir, meantime, you can also share the your practical experience of calcium management, sir, so that it will benefit our audience.
No, I think I was already speaking on the same actually. Calcium is a nightmare for an intervention cardiologist for various reasons actually. Even as a cardiologist, I would want to have a very less complication so that I would actually have a good late night sleep. Uh, that's where this calcium actually comes in between and poses a threat both to patient's life as well as having a nightmare to the cardiologist as well. So giving a sleepless night, leaving us with suspicion always at the back of mind on the outcome of the procedure that we do in the day. And the calcium, and not just that, the technical difficulty is quite high. It's again a time taking procedure, goes very long, radiation exposure both to patient and as doctors, as well as our support team is quite high. So unless it's very well planned, it may go for hours and much longer actually. So better understanding of calcium as well as better planning, planning the with effective strategically planning on how we proceed actually is the key. So more than what we do in the cat lab, pre-cat lab planning is the key. And calcium should not be underestimated. Calcium should not be just be estimated visually. rather it's better to overestimate calcium if you're doing a just I mean cath based assessment, and that's where actually for precise nature imaging helps, and OCT is a better tool in that. As I was already mentioning, IVS has some huge limitations, and not just that, the resolution is also not very unless you are very experienced and quite used to that device. I mean, OCT is an easy cakewalk for a beginners as well. So precisely demarcating what calcium, where calcium, how depth is the how deep is the calcium and all. So that information is very crucial. Once we have that information, then the applying the calcium algorithm, and I mean keeping the tools required for intervention, we can breaking the calcium or handling the calcium in the shelf is also key. Or if not available, probably angioplasty should be done on a planned day with all the equipment should be available and be ready in the shelf. I mean, the devices, equipments needed to debulk or handle the calcium, I already mentioned. OPN super pressure, I mean, the high pressure balloon is quite effective actually in breaking calcium in concentric calcific cases. But again, we should be careful with OPN as well, because it may cause terrible dissection actually in eccentric or nodular calcium on the healthier part. So, I mean, with that, there should be that caution exercised. Uh, Otherwise, Rota and or OCT orbital actually does a fantastic job in debulking the calcium, and helping us to gain an adequate lumen. Once adequate lumen is gained, then subsequent procedure is like butter smooth or easy cakewalk. So, and as I already was mentioning, it's a nightmare again negotiating a tortuous as well as calcific lesion uh, with a stent, because the stents often get easily dislodged, and when unless it's very well gripping to its balloon and integrity is well maintained, either it gets dislodged or the stent actually gets fractured, and the fractured stent, if you're deploying, also gives, I mean is associated with higher mace events. So the I mean integrity of stent actually gets very badly hurt in these calcified lesions. So that's where probably guide extension catheter taking it deeper into the coronary, so that stent actually goes smooth inside the guide extension catheter and gets placed. I mean, we can deploy the stent without actually the architecture disturbing the stent. Stent. What you call the architecture or stent. Integrity. So these are all the subtle things, but they do make a difference in actually both procedural as well as outcomes in and making it easy for reducing the adverse cardiac events as well. So calcium should not be underestimated. Calcium should be cautiously judged, and calcium should be optimally assessed, and calcium should be strategically very well planned and executed. And Giants actually in the modern Gen stents actually precisely Giants here actually is buttery smooth in negotiating torches and calcific lesions, and makes our job quite easy even without guide extension catheter. Uh, so yeah, that's about it. I don't get to see the audience, so I would want any of you to share your views if at all you're seeing me, share your views or share any thoughts and questions. Probably we'll exchange our knowledge.
Sir, actually, audience link is different, sir. So they are seeing you, and if they have any questions, they can.
Sir, we have close to around 32 people as audience, sir. So there's
Oh,
also a
okay,
question
Kiran.
panel for them to ask the question, sir. Maybe
Okay,
if there are
okay.
any questions in the box, Govind, you can just read it out to sir,
Yeah,
so
yeah,
that sir can.
yeah.
Yeah. Naresh, any questions from the chat box?
Yeah. Actually, we have one question from Mr. Pradeep. So, question is, if don't mind, could you please explain unforgettable complex calcified case, sir?
Hmm. Uh, there are many unforgettable calcified cases actually. I would want to share my colleague's case where I was also part in and assisting him and helping him out. Actually, that's a terrible nightmare. For social reasons, he's actually relatively younger. Walked in and because treadmill positive, it's an elective case. You take him for an angio. I mean, because treadmill is positive, not hardly any symptoms actually. Diabetic, very uncontrolled, mid 40. You take them for angio to check what's happening with the anatomy. But it is actually osteoprox circ was tight and it calcified actually. The rest of the vessels were reasonably okay. And we took him for ad hoc PTCA. And that's again a limitation in judging calcium with angiographic assessment. We didn't expect it to be terrible calcium. We thought it should be at 5-10 minutes angioplasty. So my colleague was doing it, and he dilated with a three balloon. Three balloon. He did not. He placed already. Sorry, he placed a 2.5 stent already, 2.515 or something like that in the proximal LCX. But the calcium is actually eccentric calcium, and it's a very hard calcium. So stent is not optimally expanded, and it was ugly looking in angiographically. So he wanted to dilate it with a higher pressures. So he took a three NC balloon, and then he went to 16 atmospheres, 18 atmospheres. He did not actually yield. I mean, there's a dog bone. He did not yield. So he went to 24 atmospheres. Unfortunately, the balloon burst and circ vessel also ruptured. It's a terrible. I mean, what you call that Ellis classification. It's advanced stage coronary perforation. So he went into panic mode. Nobody was next. Then my cath lab team called me. But by the time I went in there, out of panic, actually, they pulled out all the wire and entire assembly. So he was already in terrible shock and CPR ongoing. So we had to quickly re-engage it, and take a wire and put it into the circ. And every time you take the wire into circ, it actually goes into the pericardium because also already rupture. So at once, actually, it slipped with the ease into the native circ, and then we had to occlude the vessel with a balloon to seal up the rupture, to seal the vessel perf, and then it's not an infarct vessel, which actually is helpful and convenience, because infarcted vessel, even if they're occluded, hardly any hemodynamic changes observed. But these are like the elective patient. So the moment you occlude, they'll have angina and hemodynamic disturbances, and also that was a terrible nightmare. Many list is many actually. I got couple of cases. Stent got dislodged, and one stent dislodgement was so terrible that actually uh, went out of wire, or rather wire got pulled out. It was floating in the coronary, and you cannot even actually snare it so easily. So we had to take one more wire next to this stent, inflate it distal to this dislodged stent, then pull the stent as well as the inflated balloon entire into the guide, and then we pulled it slowly in. It was actually done through a femoral. Entire assembly was getting pulled, and there is a high chances that the stent may get actually mm, slipped out of this balloon, which is creating a tamponade there and can go into the carotids. So should we do that risky procedure, or should we just deploy the stent into the wall? Then it becomes a three-layered metal, which is again terrible. So luckily, we could actually get it into the femoral artery, close to the femoral sheath, and then we removed entire thing in bulk. So, we were successful, but that was terrible and nightmare and procedure. It went on for 3 to 4 hours. And the list goes actually, never ending. The moment I'm speaking of second case, I'm able to recollect the other case, third, fourth, something like that. So calcified cases are like seriously terrible. Stent dislodgements are quite high. Stent fractures, we see it like, once in 3-4 days actually. A stent fracture, at least if you observe, that's fine, because the fractured stent, if you deploy them, and it actually leads to vessel inflammation and ISR is quick quick ISRs. But at least dislodge stent, the companies and the industry people are quite, friendly and thankful. With the moment stent is fractured, we actually, switch it with a newer stent free of cost. But stent fractures are quite common in negotiating this calcified lesion. So that's where guide extension catheters actually. We got Guidezilla and Telescope. All these guide extension catheters actually makes jobs so easy and convenient actually to overcome this problem. So calcium, yes, it's a nightmare.
Thank you,
Nodular
sir.
and normal
Yeah.
angioplasty. Somebody, Dr. Charles Darwin has raised it. How can we identify nodular? We can only assume, we cannot certainly establish, but we can easily actually assume nodular calcium because you see a concavity in the angiographic flow at the calcific part. So it's a visual impression. If you see a concavity, and the calcium is likely to be nodular and protruding into the lumen. So, and it is more obvious in one view. It is not like equally seen in both the orthogonal views. If it is like equally seen in both the orthogonal views, it should be concentric or, or near concentric calcium. But nodular calcium, you very well get to see in one view. One plane actually, and the angiographic flow would be like, at one point it will be really concave. So you can very well assume that it's a eccentric or a nodular calcium. Nodular and eccentric calciums are really crazy and tricky to handle. They are not quite easily handled with the rota and orbital also. They are they are best handled with orbital, but always there is a risk of wire bias related vessel perforations and also all these things to be kept in mind.
Thank you, sir. Thank you for sharing those nightmares cases, and I hope really it will be really useful for all the audience. I think it's time, sir. We can close. So
Sure.
on behalf of Abbott, I would like to thank Sir Ashok sir for presenting the topic. Also, I thank all the audience for taking time and joining for today's webinar. So with this, I would like to conclude today's webinar. Thank you all. Good night.
Ashok sir, thank you so much, sir.
Thank you all the audience, and thank you Abod, thank you Govind, thank you Arun. Yeah, good day, good night.
Thank you, sir. Good night, sir.